So we'll start with the first presentation by Dr. Ankita Shirude.
Good evening everyone. I'll be presenting a case of lid reconstruction with tarsoconjunctival graft and skin advancement flap in a case of aggressive BCC. BCC is the second most prevalent skin cancer in Asian Indians. The most common etiological factor is ultraviolet light exposure and is most frequently seen on the lower eyelid. A biopsy is the most reliable diagnostic modality. Nodular, nodulo-ulcerative and sclerosing are the known clinical variants. The other subtypes include cystic, adenoid and pigmented. The slide is not. So a 74-year-old female farmer by occupation came to our OPD with complaint of brownish mass over right lower eyelid since 4 to 5 months, which was insidious in onset, gradually increasing in size, painless in nature, not causing any other ocular complaint. The lesion had well-defined borders, pearly raised rolled margins, central ulceration and fine telangiectatic vessels underneath. Distortion of eyelid margin and loss of lashes was noted. Punctum and canalicular area was not involved. As you can see in the figure, the vertical diameter of lesion was 10 mm, horizontal 8 mm, and the distance between lesion and punctum was 6 mm. Both eyes showed cataractous changes with best corrected visual acuity of 20/40. The rest of the anterior segment was within normal limit. Preauricular and submandibular lymph nodes were not palpable, and her systemic examination was within normal limit. The incision biopsy of the growth in the right eye showed a nest of atypical cells surrounded by dense fibromucinous stroma. The cells had scanty cytoplasm, increased NC ratio with peripheral palisading, and as you can see in figure B, melanocytes were present, which confirm the pigmented nodular variant of BCC. A full thickness pentagon excision of mass from right lower eyelid was carried out, ensuring a 4 mm clear margin from all sides. Intraoperative frozen section confirmed the tumor-free margins, and a defect of 14/16 mm was created. The posterior lamella was reconstructed with ipsilateral upper eyelid free tarsoconjunctival graft. A 5/8 mm graft was harvested, leaving behind 4 mm intact tarsus without affecting the function or aesthetic appearance of the donor upper eyelid. Anterior lid margin was formed by suturing the donor graft to the adjacent native tarsal plate at the gray line. Anterior lamella was reconstructed with skin advancement flap from the cheek and then sutured to the graft. Orbicularis oculi muscle fibers were also sutured with the adjoining graft. The donor site of the upper eyelid showed signs of healing, and there were no signs of recurrence on 6-month follow-up. So for larger eyelids spanning 50% or more of total horizontal eyelid, Hughes flap technique is practiced for successful closure. Our patient was not willing for a 2-step surgery, so an alternative surgery with tarsoconjunctival graft for posterior lamellar reconstruction followed by skin advancement flap for anterior lamellar defect was planned. Tarsoconjunctival grafting is a simple, cost-effective, single-step surgery that avoids secondary surgical intervention in the affected eye as well as the surgical intervention in the contralateral unaffected eye, reducing the complication of eye occlusion, patient discomfort, and amblyopia. Mohs microscopic surgery is now considered gold standard in management of periocular BCC. Due to the limitations of our institution, we opted for intraoperative tumor resection with frozen section. Even after radical resection, there is 5% risk of recurrence, which may exceed to 38% if the excision is incomplete. The other non-surgical modalities to treat BCC include irradiation, cryotherapy, photodynamic therapy, imiquimod cream, and oral chemotherapy. So to conclude, surgical treatment with histopathological margin control remains the gold standard for treatment of periocular BCC, followed by eyelid reconstruction with restoration of eyelid structure and function to as near normal as possible. Thank you.
What are the limitations of this procedure of the tarsal conjunctival flaps? Limitations or shortcomings or whatever? Yeah.
Sir, larger size, if there is a larger defect, this was a 50% defect. If it is a larger defect, we cannot excise more tarsal plate because it will affect the upper eyelid.
Yes. So we have to preserve the tarsal plate. If you sacrifice more tarsal plate, then the cosmesis and plus functional part also, that will jeopardize. Yeah.
Yes. Thank you.
Yeah. So I'll invite the second speaker. Dr. Divya is there. Yeah, she'll be talking about the bleomycin boost.
Good evening, everyone. I'm Dr. Divya Srivastava from RIO PGIMS Rohtak, and I'll be presenting on the topic bleomycin boost, transforming eyelid reconstruction. So this is a case report of a 60-year-old male who presented with a right lower lid swelling, which was painless, progressive, and gave the typical look of a rodent ulcer. Our patient was also a chronic BD smoker and alcoholic. On local examination, a 4 into 2 centimeter growth was noted, which had rolled out margins and pigmentation and madarosis. So a provisional diagnosis of basal cell carcinoma was made, as we can see. So since our tumor involved more than 3/4 of the lower eyelid area, it was a large size tumor, what we planned for our patient was a debulking with intralesional bleomycin injections and then followed by a wide excision and lid reconstruction. But before this, a histopathology sample was taken and a diagnosis of BCC was confirmed. So the main question before us was that, can it prove to be useful in a tumor of this large size? A short note about bleomycin. It is an FDA-approved anti-cancer drug which has been used for various ocular and non-ocular tumors like squamous cell carcinomas, Hodgkin lymphomas, basal cell carcinoma, Kaposi sarcoma, non-responding capillary hemangiomas, and orbital lymphangiomas. It is a glycopeptide antibiotic and anti-neoplastic drug which acts by inhibiting the G2 phase of the tumor cells. The main adverse effect is bleomycin pulmonary toxicity and skin pigmentation, but very less side effects have been noted with its intralesional use as yet. So how we do it? It is available as a 15 IU injection, and we reconstitute it with a 15 ml normal saline to make it 1 IU per ml. And depending on the size of our tumor, we decide the dose, how much is to be given. So for our patient, we decided to give 2 international units per setting using the multi-puncture technique, as we can see. So the results, with the first injection only, we got very drastic improvement in the size of the tumor and debulking. This was the postoperative 1-month picture, and we went for another 4 doses. This is the 3-month picture, and this is the final result after 4 doses at monthly interval, 4 months apart. So now the patient was to be taken up for surgical excision of the remaining growth. So the question before us was that what procedure we need to do right now. So ideally, we advise the patient to go for a cutler blade procedure, which is a 2-stage process, 4 to 8 weeks apart, as we can see in this another patient with upper lid meibomian gland cancer. But our patient was reluctant for this surgery because of its long visual compromise, which he could not afford. So in view of the progress with the intralesional bleomycin injections that we got, we wanted to plan something else for our patient. So as you can see, the current lesion the patient has, it spares the punctum as well as the canaliculus, which we confirmed by doing a syringing, which was patent. And the lower lid margin was also intact. The lesion was also not very much deep. And the patient was reluctant to give consent for the cutler blade procedure, and he was also very compliant with his follow-ups. So what we planned was a wide surgical debridement with intralesional bleomycin injection, and we wanted to see the result, how the patient responded post-operatively with this. So these are the post-operative results. This is the post-operative day 1 picture. As you can see, another thing that we did was we put a frost suture on the lower eyelid in view of the iatrogenically created ectropion, and we put it for 3 weeks with traction. This is a post-operative 3-month picture. We can compare with the results we get with the cutler blade procedure. Cosmetically also, it was better for this patient. This is a pre-treatment picture, and even after 1 year, we have yet not received any post-operative recurrence, and the patient is stable with us, and he does not have much epiphora. So further plan is that we follow the patient 3 monthly. We can repeat intralesional bleomycin injections if any recurrence is noted, and we can take up the patient later on for cutler blade procedure or any other excision biopsy plans. So various studies have been done for various tumors like BCC, squamous cell carcinomas, and keratoacanthomas, and bleomycin has given 98 to 100% cure rates as well. So the take-home message is that mainstay therapy is always going to be surgical wide excision for these tumors, but intralesional bleomycin gives us the benefit of debulking the tumor mass, decreasing recurrence rates, and even handling the positive postoperative margins. So we could not get a frozen section done while we were doing the excision. It wasn't available in our institute. But it also helps in postoperative margin. Even if it's positive, we can go for intralesional bleomycin injections. And side effect profile is also very low, noted with the intralesional injections. So we can conclude that it's a very good and effective therapy, and more studies need to be explored regarding this. Simple solutions can sometimes give really remarkable results. Thank you.
So you just did the lamellar excision of the lesion?
Yes, sir. As much as we could visibly see, we excised the tumor, and at the base we gave intralesional bleomycin as well.
And what was the base on histopathology? Was it clear from the tumor?
So that's what I told, because frozen section facility was not available. Yeah, after we
on histopathology also we can say.
Yes, sir. Yes, sir.
So that was clear.
Yes, sir. Yes, sir.
There was
The
no invasion
yes, sir. The histopathology later on was clear.
Okay.
and recurrence was also not noted. As yet the patient is on follow-up with us, but yet the patient is stable in 1 year. Thank you.
If at all there was a punctum involved or
Yes, sir.
the canalicula had a pigmentation, so
Yes,
what would
sir.
have you done for this case?
Sir, the punctum was initially involved, but we could have gone further with the
Involved in the
injections
sense?
only.
Involved means it was pigmented?
Yes, sir.
How we were saying like?
Sir, it was pigmented, but initially the syringing was, the punctum was also affected. It was, the tumor was pushing the canaliculus, but after the injections, the punctum was visible and the canaliculus was also patent. The injections really gave us an extra edge.
So
in
generally
that
there is a
case.
dictum that if the canalicula system is involved,
Yes, sir.
you do DCT in those cases. You have
Yeah.
to do extensive excision of those tumors.
So actually we could not take, because before, as I said, that pre-treatment, we did not know that if the canaliculus is involved, but because it improved and syringing was patent,
It's not
that's
about
why we
the
did not go for
patency
excision of
the
that thing.
Canalicula system.
Okay, sir.
It's about the
Involvement.
involvement of the system.
Okay, sir.
It
If
won't
it is
occlude
in-
it, but it will get spread.
Dislodge.
Yeah, further erode the bone and all, and it may spread.
Yes,
So advice for this case will be
Yes, sir.
keep a long-term follow-up,
okay, sir.
at least every 6 monthly,
Yes,
and do have a ENT checkup as well,
okay, sir.
endoscopy.
Thank you, sir.
Okay, next speaker, Dr. Tanima. Yeah, she'll be talking on the blepharocallosis syndrome.
Good evening. I will be talking on blepharocallosis syndrome and its atypical presentation of Asher's syndrome. Blepharocallosis was first described by Joseph Baer and was termed by Ernst Fuchs, which means the eyelid to slacken. It is defined by the episodic inflammation of the upper eyelids, mostly bilaterally.
Wait. Your slides are not.
Mostly bilaterally, with 3 to 4 episodes per year. Females are more affected during the adolescent or the pubertal age group, although unilateral presentation, lower lid involvement, and old age presentation have also been seen. The blepharocallosis occurs in 2 phases. First is the intermittent or the active phase, where we find painless, non-pitting edema lasting for 2 to 3 days. This again consists of 2 phases, the hypertrophic phase, where we find prolapse of the orbital fat due to the weakness of orbital septum, giving a fuller orbit appearance, and the atrophic phase, where there occurs fat atrophy, giving a hollow orbit appearance. The second phase is the quiescent phase. As the name suggests, the disease remains quiescent for at least 2 consecutive years, giving the characteristic cigarette paper appearance of the eyelids. So here we represent 3 cases, all of them presented with non-pitting bilateral edema. The case 1 is that of a 22 years female who presented at the hypertrophic phase. Case 2 is that of a 14-year male presented in his active phase, and case 3 is unusually of a 54 years male who had no other symptoms of atopy, asthma, or systemic association. We did all the pathological investigations and ocular investigations which came out to be in the normal range, so we started them on only oral antihistaminics and oral anti-inflammatory agents, which gave a very good response. The etiopathogenesis, some studies says that it's a familiar variant of angioneurotic edema. At the cellular level, we find perivascular infiltration of the lymphocytes, staining of the MMP3 and MMP9, and abundant IgA deposits around the elastic fibers in the skin, with marked decrease in these elastic fibers. Due to repeated episodes and marked decrease in the elastic fibers, it gives to disinsertion of the ligamentous structures, which give rise to the complications of the blepharocallosis, that is entropion, ectropion, eyelid thinning, lax eyelid skin, levator dehiscence, ptosis, orbital or lacrimal gland prolapse. Konai et al. Has given in his study with RT-PCR analysis of mRNA expression of elastin in the skin of blepharocallosis with that of healthy controls, and he has said that there is no such difference found in both the studies. He suggested environmental factors and other matrix components to be involved in loss of elastic fibers. Another etiopathogenesis associated with the blepharocallosis, which is also an atypical presentation, is that of Asher's syndrome, which leads us to the case 4 of a 26-year female who used to present to us for past 7 years with recurrent attacks of bilateral non-pitting edema, who was in a quiescent phase for 2.5 years. Also, she showed signs of thyroid gland swelling and double lip. Laboratory investigation in her were also normal. So now she came with the right eye lax eyelid skin and left eye drooping of upper eyelid for last 1 year. So we define this to be Asher's syndrome, which is characterized by blepharochalasis associated with double upper lip and euthyroid goiter. The double upper lip occurs due to the hypertrophy of the mucosal zone of the upper lip with persistence of the horizontal sulcus. The complications mostly involve ptosis and lax eyelid skin. In this patient, the management that were available were to treat the active disease, we had medical management, and to treat the surgical complication, we had the surgical options like blepharoplasty, ptosis correction, canthal tendon reattachment, and fat grafting. In this case, we did for the right eye a blepharoplasty, and for her left eye ptosis, we did a liver tapinosis reattachment, and here is the outcome. So there are some differential diagnoses which simulate the blepharochalasis syndrome. It is important to identify them before stamping it as blepharochalasis. Asher's syndrome occurs in less than 1 in 1 lakh people where all 3 signs may not be present. 80% cases shows blepharochalasis, 10 to 50% shows non-toxic euthyroid with a normal thyroid profile. And the take-home message in such cases are any surgery to be done in the eyelid should be deferred for at least 1 year from the previous attack of eyelid edema. And since it's a very rare syndrome, so differentiating it from other simulating conditions is very important to give a proper symptomatic relief. Thank you.
Nice presentation.
Thank you, sir.
About the fourth case that you discussed.
Sorry, sir?
About the fourth case
Yes,
that
sir.
you discussed.
Yes, sir.
Initial picture didn't have pigmentation on the right.
No,
side
sir.
of the
No,
eye,
sir. No,
and
sir.
Later she had.
Yeah, sir. Yeah, it was actually she was coming to us for a very long period. So later on, she developed some pigmentary changes over her eyelids.
Only on the half side.
Half side,
right?
yeah. Yes, sir.
So did you look into it? What was the reason for that also?
So we did take up her for a skin consultation, but they said it is due to the recurrent attacks of the edema which led to the depigmentation over there. Thank you, sir.
ठीक है. Next presenter, Dr. Swati, lymphoma of orbital apex. She's not there. Okay. Then Nikita Sharma. She will be presenting on the ossified choroid.
Good evening, everyone. So, as for introduction of choroidal osteoma is a rare benign ossifying tumor of the choroid of unknown etiology and is an unusual form of intraocular ossification. First described by Gass in 1978, the predominantly occurs in healthy young females in 2nd or 3rd decade of life and located in juxtapapillary or peripapillary area and is mostly unilateral. Usually asymptomatic but may present with mild or severe blurring of vision, metamorphopsia and visual defects. Although it has characteristic clinical fundus pictures, B-scan, OCT and fundus fluorescein angiography, findings are diagnostic to differentiate. Our case was a 16-year-old girl which presented to us for blurring of vision in left eye for 1 year. She had no other ocular complaints, no history of ocular trauma or symptoms suggestive of any past intraocular inflammation. She had a history of right-sided pleural effusion with pneumonia with severe anemia 6 months back, for which she had been treated and given a blood transfusion to correct the anemia. She is also a known case of moderate mitral regurgitation, which are all incidental findings. No similar complaints in any other family member or general examination were unremarkable. Her ocular examination was best corrected visual acuity in right eye was -0.5 with -0.5 cylinder at 30 degree was 6/6 and at 90 degree -0.5 was 6/9. Near vision was normal, NCT was within normal limits, color vision and color contrast were decreased, pupillary reaction and slit lamp examination all were normal, within normal limits. Fundus examination of the right eye was normal and left eye showed clear media with normal disc and an orange colored choroidal lesion with well-defined borders with molted depigmentation of overlying RP over the posterior pole involving macula. The central area of blackening likely corresponds to decalcification of choroidal osteoma. FFA of left eye shows central hypofluorescence with surrounding speckled hyperfluorescence in the area of chronic RP decompensation. The central hypofluorescence likely corresponds to the deossified area of choroidal osteoma with atrophy of RP and choroid. Late diffuse staining was noted. On OCT of left eye, concavity of retinal contour involving foveal area, hyperreflective lesion with lamellar pattern noticed with overlying disorganization of outer retina or RPE. Undulations in the lesions were noted due to formation of reabsorption base suggestive of deossifying nature of the choroidal osteoma. B-scan showed a slightly elevated hyperechoic choroidal mass with acoustic shadowing, giving a pseudo-optic disc appearance on, as seen on B-scan, and A-scan showed high spike in, intensity spike. Perimetry, there was a field effect corresponding to the area of our defect. In literature, the largest case series included 61 patients over a period of 26 years of ocular oncology practice in major tertiary care center. Exact etiology remains unknown, but few theories on its origin includes congenital causes, osseous choriostoma, inflammatory conditions, and endocrine disorders. Clinically, it is a unilateral located in peripapillary and juxtapapillary area and may extend to macula. It is oval to round in shape with scalloped or geographical borders with overlying blood vessels ranging from 2 to 22 mm in size and 0.5 to 2.5 mm in elevation. It appears yellow-white to orange-red depending on the thickening and thinning and depigmentation of the overlying retinal pigment epithelium. Histopathologically, choroid is replaced with mature cancellous bones with dense trabeculae and endothelial lined large cavernous spaces and small capillary blood vessels. No hematopoietic activity is seen. CNVM and subretinal fluids, hemorrhages, and serious retinal detachments are important complications which were not present in our case. Our patient diagnosis was made basically on the characteristic clinical and ultrasonic pictures and fundus fluorescein angiography. Till now, it's been 9 months post diagnosis, and the patient is still stable with the same refractive power.
What are the main differential diagnoses whenever you come across such cases? And though it is a rare presentation that the calcification in the choroid or the choroidal osteoma. So what are the main differential diagnoses commonly mimic like this, and you may confuse and you may miss if at all if this patient comes to you?
So metastatic cancers, melanomas.
Melanomas will be a different entity, and the diagnosis criteria is different as compared to the choroidal osteomas. Yeah. Okay, the complications you have narrated that may give rise to the
CNVM.
Yeah, CNVM, hemorrhages, and all those things.
Sir.
Yeah. So what is the definitive treatment for this? If at all, if you diagnose this and now you want to treat the condition, so which is the main or the easiest modality by which you can treat such conditions?
So if it develops CNVM or a bleed, we have to give anti-VGFs.
So till that CNVM and bleed doesn't come, you will not treat the condition? That is a treatment of complication, but per se if you see the condition like this, you have to treat it, no? You have to think of some differential diagnosis, then of course the investigations and all also you have to plan, and you have to treat it so that the complication should not develop. So early treatment will prevent the occurrence of the complications. Anyway, okay.
Thank you.
Sir, you want to ask something? Dr. Vishal wants to ask. Okay. So now next presentation by the Dr. Nikita Ahuja. She will be talking on the necrotizing scleritis in granulomatosis with polyangiitis.
Is Dr. Diksha here?
Is there? Dr. Diksha is also there, so she can load her presentation on the next podium.
Or Dr. Swati Sharma? No.
I think is the last presenter. Okay, please.
Good evening everyone, I am Dr. Nikita Ahuja from AIIMS Bhopal, and my case is necrotizing scleritis in GPA, management and outcome challenges. So I would be presenting a case of 44-year-old Asian female with chief complaints of left eye pain on and off since 1.5 years, along with redness in the left eye since 1.5 years with loss of vision since 3 weeks. She was a known case of left eye scleritis for 1.5 years with on and off systemic and topical steroid therapy. She had pain in left eye since 1.5 years, which was gradual in onset, progressive in nature. It was throbbing type, aggravated by ocular movements and radiated to temple and jaw areas, associated with photophobia and redness. She recently developed diminution of vision in the left eye for the past 3 weeks, which was insidious in onset and progressively worsening. It was associated with multiple episodes of fever, shortness of breath, and on ENT she had left ear pain, and on ENT evaluation, it revealed central tympanic membrane perforation. Other than GPA, she is also known case of hypothyroidism since 2 years and primary biliary cirrhosis. There was no history of epistaxis, sinusitis, arthritis, weight loss, malar rash, or seizures. And she was already on and off therapy, both steroid and both oral and intravenous steroids, along with topical, which was going on since past 1.5 years, and also on thyroxine. The family history was negative for any autoimmune disease and any infectious disease like TB. So on local examination, when the patient presented to us, the vision was PL positive and PR inaccurate, and extraocular movements were reduced in all the quadrants and painful. As we can see here at 11 o'clock, there is a necrotic scleritis foci with perilimbal corneal perforation along with uveal tissue prolapse from 9 to 11 o'clock position, and infiltrates overhanging with overhanging margins at 8 to 1 o'clock position. So on further examination, the patient was reluctant for fundus examination, so we did a B scan which showed diffuse chorioretinal thickening with T sign indicating posterior scleritis along with exudative retinal and shallow choroidal detachment. And other eye examination was within normal limit. So we came to the provisional diagnosis of necrotizing scleritis with limbal perforation with exudative retinal and shallow choroidal detachment. We subjected the patient for systemic examinations like chest X-ray, which revealed multiple bilateral cavitary lesions. CRP was raised and ANCA came positive with IG raised. On PET scan, there were hypermetabolic lesions noted around the left intraorbital regions with lateral surface of the left lobe. On management, we put the patient on IVMP 1 gram for 3 days, after which we shifted them to oral prednisolone 1 mg per kg along with appropriate tapering, followed by injection cyclophosphamide 1 gram, which were 2 doses 10 days apart, and the third dose was 2 weeks later, along with mycophenolate and supracal. Locally, she was put on topical steroids and cycloplegics along with antibiotics and anti-glaucoma drugs. In alliance with pulmonary and rheumatology consultation, patient was regularly followed up on the above mentioned treatment. So after 3 cycles of cyclophosphamide, the vision improved significantly with decreased lid edema and healed necrotic plaque supranasally, as we can see, with decreased limbal infiltrates with PUK sequelae. And after on the B scan, the retinal detachment was resolved. On further follow-up after 6 cycles of cyclophosphamide and the current picture, the patient shows the necrotic scleritis foci was resolved with overlying non-perfused episclera and conjunctiva eventually perfusing over time. There was resolution of perilimbal infiltrate as well. For further management, with discussion with rheumatology and pulmonology, we have the patient to start on biologicals such as rituximab. It could have been complicated, like we could see that PUK has occurred already. So to summarize, even after 6 cycles of cyclophosphamide, patient disease activity still persisted. So for further management, rituximab could be a desirable approach. Thank you.
Is that a retinal detachment or a choroidal, subchoroidal fluid got dissolved?
There was inflammatory fluid along with exudative retinal detachment and shallow choroidal detachment.
In the previous B scan, the patient had this thing. Okay. It's indeed a very rare disease, as well as it's very difficult to pick up, do the early diagnosis in these cases, and it's very well picked up by you people and well managed. And rituximab is the treatment of choice.
Yes, she is on follow-up with us now, and we are planning to give start rituximab after rheumatology consultation.
And her age was 42.
44 years.
44. Thank you.
Okay. So thank you for all presenters who presented today's all these interesting cases and all. So that's all from our side. Yeah. Thank you.
We can have a group picture.